My diabetes diagnosis was kind of like the scenic route. I had gestational diabetes with both my children, and I remember the doctor telling me within 10 years of your diagnosis of gestational, I would have full-blown diabetes, and I kind of waved it off. And they kept me on metformin, which a lot of African Americans are a little hesitant to be on medication, but with a strong familial history of a mother and a father both being diabetic type 2, combined with the gestational diabetes, it made me very high risk for getting diabetes. So I agreed to go on metformin for pre-diabetes. I remember a day when I was like, oh, I'm hydrating really well today. I'm good because I'm hydrating really well today. But, oh my goodness, I'm hungry. And something told me, maybe this isn't just hydration. So I saw my PCM like, hey, I'm having this, this, and this. And they were like, well, let's check your blood sugar. And lo and behold, they did a hemoglobin A1C, which is the 3-month measurement of your sugars over that time. And of course, it was elevated.
Time to embrace change and be about that life.
This is Dr. Bass with the About That Life podcast, the podcast about life or living intentionally forever. As you all may know, November is Diabetes Awareness Month. And whether you believe it or not, diabetes has been increasing in the United States and across the world for quite some time. Several years ago, we referred to type 2 diabetes as adult onset. But unfortunately, due to sedentary lifestyle, inactivity, and overprocessed foods, many of us are starting to see that name shift from adult onset just to type 2 diabetes. Now, when we think about it, what are the causes? What are the issues? Diabetes is a condition of excess. But we won't really focus on diabetes. We'll focus on a host of conditions that impact your metabolic health. Now, today, I just didn't want to get just anyone. I wanted to get an expert, someone that I respect, someone that I know. Yes, we are friends as always, but she is an expert in her field. She is a clinical nurse specialist, a nurse anesthetist. I read through her bio, summa cum laude, I don't know. I know she's too humble, far too humble, but today she's going to talk with us about her role as not only a provider caring for some of the sickest patients, but also as a patient herself. So I want to introduce to some and present to others Miss Teresita Scott. How you doing today?
Hello, Dr. Bass. I'm doing well, and yourself?
You doing all right?
Yes.
You doing all right? You're looking great. I can tell. I don't know what's going on. I mean, you done walked back through a time machine, done found the fountain of youth, and don't even know that. I'm mad that you ain't told me. I got more kids than I got hair now. So I know we're just coming through the Thanksgiving holiday and had some time to enjoy ourselves. And that's a time where we have a tendency to have a little excess. How was your Thanksgiving holiday?
It was great. Lots of good food.
I'm not judging. I was in the same boat. Mine was plant forward, though. I had a lot of great vegan options. We had greens, beans. We had all that, right? But it was good. Now, I had a chance to read through your bio, and I just want to say it's a story or a timeline of leadership, a timeline of history, a timeline of culture where serving your country has become something that's passé. And the fact that your bio led in with service and it closed out with service, how has that impacted you? And we'll get into what you do now. How did that impact you in making some of the decisions that you made from your desire to do healthcare?
Well, I joined the military from my college years. I was already a freshman in college. I don't think that was in my bio. And I was literally watching TV and the commercial came across.
Wow.
And I was like, I want to join the military. And everybody thought I was a little crazy because I always talked about just going to college. But I found a greater purpose in service. I still gravitate towards that because I retired and I work at a military facility because that is still...
You couldn't get away from it.
That
you
is
said,
still...
I did my time. I'm staying with it.
I mean, I love the population. I was once that population, so I still want to serve that population.
Wow. That desire for service, that desire for excellence, and it's shown, right? I mean, and again, summa cum laude, magna cum, which one were, I know you were at, that means top. So you were the top and far too humble. From there, you say, you know what? don't have enough knowledge. I want to get let me get an MBA. So you went and got the MBA. Then you said, okay, let me advance my clinical skills as a nurse. And for those of you all that don't know, and I always say this, nursing school is literally medical school. We're trying to get out of here. We ain't trying to stay extra, but nursing school is exactly the same. And so you learn that discipline and talk about what it meant to kind of take care of that first patient. Because I know what my first patient experience was, but when you were a nurse,
it was scary because where I started was on a med-surg floor where I had like 11 patients and they each had like 11 plus medications and it required attention to detail, organization, and prioritization. It was huge.
Well, when I think back to my first time where I was out of medical school, because medical school is still a controlled environment, and most times the nurses help keep you out of trouble, whether people know that or not. Nurses help keep you. Medical students, if you are watching this, find your nurse on your floor. Let her or him take care of you, okay? But I remember that first time when I was doctor. Right. And it felt good until you got that call at 3 a.m.
Yes.
You know, and you trying to, the dose of Tylenol.
Yes.
But it's this uneasiness because you know that you're making decisions that can impact the lives of those around you. And what I want you to do, because I've had a host of different healthcare professionals on to talk about that pathway. We know that nursing school is different. And then the pathway for you to decide to say, hey, look, I want to take it a step further and actually spend just as much time as I did in school. So talk about if someone wanted to become a nurse and then go on to more advanced practice as a nurse, talk about that pathway and the steps or how someone could do that.
Nursing school in itself is 4 years. Depending on what path you want to take, like as an advanced nurse practitioner, there's additional schooling. The amount of years depends on the discipline. I'll focus on nurse anesthesia because that's what I know intimately. It's now an additional 3 years and you come out with a doctorate. Wow. When I went through, I came out with a master's and it was 2.5 years. So they added that extra half year for research. There are some prerequisites. I know in the military, you have to have a year of critical care, so ICU experience. In the civilian, there aren't the same requirements, but it helps to have that ICU critical care piece. My path, for example, I was a cardiac care ICU nurse. So it kind of catapulted me into anesthesia because in that field of ICU nursing, you have to be able to make decisions. So I had a little taste of autonomy and I liked it. A little taste because the cardiothoracic surgeon was not in-house. They were by phone, readily available, and came in expeditiously when called if needed, but they expected you to do an intervention, maybe like a fluid bolus or change a position or something, and you would call them and you would say, this is what I did. They would give you an order to cover, you did, and then they would tell you what else to do. They would decide if they needed to come in-house, but they relied on you heavily to keep their patients alive until they could get there.
Exactly.
You know, anesthesia was just naturally the next step because this is the highest.
That's what I was going to say. What made you, because when I think about all the things you could have done.
Right.
And like I said, she is a friend, but we have huge discussions about cardiovascular care. And I'm thinking, why don't you go to I don't need to go to medical school, right?
I am at the epitome of nursing.
Like, there ain't no higher. But this is before you did that.
Yes.
You were telling me.
Yes.
So what made you pick? Because that's something that you just, find people that we've essentially put into a medically induced coma, bring them back safely, and, take on all those medical problems in an enhanced state where they have heightened stress. Yeah, sign me up for that. Right. Sign me up.
Well, in the ICU, I got to receive patients from anesthesia providers, and I was in awe of what they did. And I was a little nervous about it, but someone told me that I would be great at it. Someone in anesthesia, they were like, you should really look into this because when I come and I give you my patients, you're knowledgeable, you know what to do, you know how to assist, when we would have codes. And so I was encouraged. Then I got pregnant with my first child. And my nurse manager at that time, I will never forget, she was like, are you going to apply for anesthesia school? And I was like, not, because I'm first time mom and I'm going to look forward to, And so, and so she asked me another question. She said, are you going to apply for anesthesia school or are you going to deploy 6 months after your child is born? And I was like, can I have your recommendation, ma'am? And so I applied And it was the best decision that I ever made because it was timely. She didn't even remember the time that I spent away. So she had no recollection of that time. So it was the perfect time.
Because I know that work-life balance and that construct of burnout is something that physicians and even patients feel the brunt of. I love cardiology. I'm not going to say I would do it for free. But I know that when I finished my internal medicine training, that was my wife and I's conundrum. She knew that if I decided to go into fellowship, I had to hit the pause button because at that time, the environment wasn't as accommodating. Talk a little bit about that work-life balance because your mom, my niece is one of the greatest swim stars in South Texas, probably the state of, I'm gonna shout her out. My little niece coming up, essentially my brother, y'all are godparents, y'all just great people, host more parties than I didn't even know. So talk about work-life balance as a nurse anesthetist.
It varies. There's so many places that we can work. The demand is huge. We have the ambulatory care centers, we have the hospital, we have the GI centers. And so a lot of times you'll find that people are doing a mix of the different types of centers to work in or the shifts that enabled you to pick up your kids after school or the condensed work schedule where you're working 4 days, getting your 40 hours or 3/12s and getting 36 hours.
Okay.
And so it's just so many ways that you can arrange your schedule so that you're still present.
You said present. And what's that mean
Just
to
a
you
difference.
as a busy healthcare professional? What does your presence mean?
Being present is different than being here. You can be in a place 24 hours a day, but if you're not engaged, if you're not helping someone grow, are you really present? I think present is just, it's all in. Just like we're all in our careers, when you come home, you got to be all in for that small snippet of time.
Right.
So.
And I love it because there's a lot of people that, I was there, you saw me.
Right.
And as a healthcare professional, that's the challenge. I was joking with the parties, but every party's a big, I said, I just figured 1360. We having donkeys and horses at a 7-year. I love that in it. Now, I can't do it. Now, don't get me.
Right.
That's not the vibe.
It's
I
work.
can't do it. But I love the fact that you're able to maintain that, stay busy, engage at swim meets, doing this. And I think, my nieces are thriving from it. Just seeing that example that you set in a busy, demanding, and then also knowing, now talk about this because you've done this, which I didn't think you'd be able. You've been able to hit the pause and the stop button, right? When they say, hey, we need you to come here, do this, stop, pause, talk about that. How were you able to do that? Because I still hadn't figured it out.
As far as like changing where I work?
Changing that pace.
Right.
And saying, I'm not about to kill myself, do X.
Yes. I was in the military I was telling you this earlier. I take great care with my schedule at this point because I don't want to ever get to the point where it affects my love of anesthesia. I have a great love for anesthesia. So I have to have balance so that I can regroup, so I can present myself the best of myself to the patient every day.
I like that.
So if you are working countless hours, like I tell people, I'm glad I don't have to do it for free, but I would, but I don't want to, and I don't want to do it in excess so that it diminishes my love. So yeah, I pause, like I have gone to outpatient for a while, but again, I have a love for hospital anesthesia too. So then I had to come back to hospital anesthesia and do it in a smaller capacity and still do my outpatient P. And it brought me the greatest joy.
Just talking about that career path and understanding just how passionate you are about taking care of patients. But now we're going to shift gears a little, right? Because I know that both of us are patients in some capacity. My discussions with you, not only now, but over time, has revealed, hey, look, I have diabetes, but diabetes doesn't have you. So talk about what it meant for you to get that diagnosis.
Well, my diabetes diagnosis was kind of like the scenic route. I had gestational diabetes with both my children, and I remember the doctor telling me within 10 years of your diagnosis of gestational, I would have full-blown diabetes, and I kind of waved it off. And they kept me on metformin, which a lot of African Americans are a little hesitant to be on medication, but with a strong familial history of a mother and a father both being diabetic type 2, combined with the gestational diabetes, it made me very high risk for getting diabetes. So I agreed to go on metformin for pre-diabetes. I remember a day when I was like, oh, I'm hydrating really well today. I'm urinating because I'm hydrating really well today. But oh my goodness, I'm hungry. What is in here to eat? And something told me, maybe this isn't just hydration. My baby was 10. So I saw my PCM like, hey, I'm having this, this, and this. And they were like, well, let's check your blood sugar. And lo and behold, they did a true test of blood sugar. They did a hemoglobin A1C, which is the 3-month measurement of your sugars over that time. And of course, it was elevated. And so it was 7 point something.
Yeah, so
It
above
was up there.
6.5
Yes.
is when we get concerned, at least as a cardiologist,
Yes.
I get concerned. So you were above 7. So the diagnosis of diabetes was made while you were on metformin. And I know you were exercising.
Yeah, and
you were doing all the right stuff.
I was still active duty. I was on metformin. I was diabetic.
You were like, this wasn't no, because I tell folks, when people say, hey, I'm pre-diabetic, I say that's like being a little bit pregnant, right?
Right. Right.
Now, when they gave you that formal diagnosis and you had the A1C of 7, what changed? Or did you say, I kind of expected it? What were your thoughts there?
It was a little bit of expectation. I felt like with my family history and the gestational that I would eventually have a diagnosis of diabetes. So there are some things that are hereditary that you can't change by exercise or diet. You can mitigate the risk. You can't necessarily avoid the diagnosis. I wasn't brokenhearted. I was like, okay, now I need to exercise. Now I need to watch my sugar intake. So just kind of doing the things to manage at that point. I've been really pretty controlled. Like I haven't seen high hemoglobin A1Cs like some of the patients that I see. And
Now,
so,
what's a high hemoglobin? As a cardiologist, I get concerned. Treatment typically starts, and again, someone else is going to quote in the comment. This is, 7.5% is when treatment starts. What is a high one? Not for you, but just what's the highest that you've seen?
I've seen 10. I've seen 13, I've seen 18. When you see high hemoglobins like that, they are really uncontrolled. It unnerves me because I don't ever want to be there. When you get to those high numbers, you're at risk for organ. Yes. And so it's a real concern. I've seen people lose limbs and eyesight, kidney disease, dialysis, and it makes management more difficult. For our elective procedures, if you come in and you have a blood sugar over 300, or hemoglobin A1C that are in the teens, you get a do not pass go.
So if someone needed surgery and it wasn't an emergency, and they came in and they weren't taking care of their blood glucose levels and come in and, well, the doctor said I was fine, I'm 12, 13, can I get my knee surgery that I've been, so that's a no.
You have to go through internal medicine and get optimized.
Before they go to surgery.
Yes. Now, if it's a knee from trauma or hip from trauma,
but you got to get it done.
We mitigate those risks. We put in an arterial line. We will put you on an insulin drip. We'll check your sugars hourly. It's a lot.
You talked about the A1C, and what that A1C translates to is actual blood glucose numbers. And so 6.5, I think, correlates with 126 or some number like that. As you go up in that percentage, as does the amount of glucose floating in the blood. And the way that I tell my patients about it, I say, think about Kool-Aid. You know how Kool-Aid can be thin and it flows better, but when you add too much sugar to that Kool-Aid, it gets sticky. And that stickiness, imagine that flowing through your bloodstream, especially those small blood vessels in the kidneys, in the brain, and my love, the heart, right? We used to consider diabetes cardiac equivalent, and in many cases I still do, but we know there's a host of other things that can occur. You talked about amputation, you talked about stroke, you talked about all these different complications that occur. So now, how did you keep yours so well controlled? Because I know people are wondering, like I told you, you found a fountain of youth and I thought we were friends. You didn't tell me about it. How did you manage this diabetes?
Well, I think it has to start with prevention, having a PCM where you can communicate your goals, and I do. So medications, for sure. Exercise. We literally have a gym next door. And my goal is to frequent it at least 3 times a week. I don't always meet that goal, but that's my goal. Cardio, weight training, hydration, very important. I can't impress upon anyone enough about hydration.
Right.
Before my PCM, I had this African-American older gentleman. He was at Wolf Hall, actually. And I can't for the life of me remember his name, but he told me something that was important. As a diabetic, he said, if you don't keep moving, the vultures will get you. And then he said, if you like cake and cookies, eat them for breakfast. So you have all day to burn off the carbs. Not that I would do that on a routine. Like, you should not have your cake and then go to bed. Because when you wake up in the morning, your blood sugar is going to be extremely high. I found that fasting, that number was really telling. At one point, I wasn't even in my pre-diabetic stage. I was impaired fasting glucose.
And that's that progression. So we talked about those lifestyle strategies, which I think are important. You mentioned exercise at a minimum, and I tell my patients that minimum is 150 minutes a week of vigorous exercise. That translates to 30 minutes a day or 45 minutes every other day, but something. And it can be something as small as walking. A lot of my patients can't move a lot. They're mobility limited. I say you can chair-ercise, right? So you can literally sit in a chair, lift your knee, lift this, put your arms over your head, and you'd be surprised on how that improves your mobility. You talked about diet. Now, you know I'm forward, right? But you don't have to be vegan, vegetarian. You just have to really eat real food. Now, I would say the data does favor a diet that is less processed, right? And more balanced, you know, has better effects. But what if someone's doing all those things? And you mentioned metformin. Any other medications? So you got metformin here, it's a pill. Then you got insulin all the way out here. In that spectrum, did you ever have to experience the addition of new medicines or any other medicines like that?
Well, I can tell you, and I don't know if it's just because of pregnancy, but when I had gestational diabetes, I was on insulin. And it was a lot of insulin. Like, I was floored at the amount of insulin because I work in the ICU. I've never had to give this amount of insulin to my patients. I was taking 22 in the morning and another 11. So like 33 to 40 units of insulin daily.
My goodness.
The concern was for the baby. If your blood sugar is not controlled, then the baby can come larger. They come and they're hypoglycemic.
Because it's used to having all that glucose.
I had a reproductive endocrinologist that was very aggressive at managing, to the point where sometimes I'd be like, oh,
something's too low.
Yeah,
I'm too low.
Like, my blood sugar's low, 40. Yeah, but I mean, baby came at a normal weight, not hypoglycemic at birth.
My goodness.
Both of them. So, yeah, I mean, the management was awesome.
So now, as you look back on
you were asking me something. I'm sorry. You were asking me about additional medicines.
Additional medicine.
So, the insulin for gestational, I've been on like Januvia, but the way the medicine works, like that specific medicine didn't really work for me. It made you diurese the sugar out. And I'm like,
diurese, just regular.
Makes you pee. And I used to tell my doctor when I asked him to take me off of it, I was like, women aren't supposed to pee sugar.
Right.
You should not have too much sugar.
I don't want to either.
For women especially, peeing sugar. And so it didn't work. But what does work? The semaglutides. That's newer.
Okay.
That's newer.
We'll talk about it then. You wanna bring up the GLP-1 receptor agonist.
Right.
That's the
I tell people it's this. But it has been life-changing for so many people. The weight loss is a perk. The control is amazing. I tell people once I got on Ozempic, I hadn't had that amount of control for a decade. Like, to see 5.9, I hadn't seen it in a decade. I used to stay around 6.2, 6.5, 6.7. You know, that was kind of where I lived. But to be at 5.9, to be 50 pounds lighter, to feel better. Because there is a fatigue and a general just blah with the beat. Like, you're slowed in everything. And so to feel normal. Now, of course, it does have its side effects. The gastroparesis associated is on top of the gastroparesis of diabetes, because that's one of the symptoms of being a diabetic in itself. So it worsens that aspect, the nausea, vomiting. And I found that in the early stages, it was worse as you stay on the medicine.
Now, how long were you on it?
Over a year, and I'm still on it.
And the weight loss, like you said, the 50 pounds. And I'm a heart guy. Very early on, we had the inklings that the GLP-1s, similar to the SGLT2s, had benefit.
Right.
But here recently, there was a trial that came out called the SELECT trial, and it was semaglutide in patients with known cardiovascular disease. They saw a reduction in major adverse cardiac events. They saw a reduction in hospitalization, a reduction in myocardial infarction. And so now, even in individuals that don't have diabetes, there's a trend to consider it when you see people that are moving in a space where further control and risk reduction from a cardiovascular standpoint takes place. Now, because the medicine is relatively new, did you have any concerns about taking a new, you know how we are, and when I say we, you know what I'm talking about, a new medicine. Girl, you're going to take that new, it's hold on. What were you, when you first were offered the GLP-1 semaglutide, what were your thoughts? What was going through your head?
Well, I had already been on Trulicity, because again, I'm always trying to be well mannered. I had done Trulicity, I had done Victoza. I think Victoza was the one that just really didn't agree with me and made me really nauseous, really symptomatic, even though they're all controlled, it's just the symptoms that come along with it. So Ozempic was better for me as far as symptom wise. And so I wasn't adverse to it at all because I'd seen the literature where it had the reductions. Diabetics are at high risk for perioperative strokes and kidney disease. So these things are being helped with this medication in addition to the weight loss. And so I'm like, okay.
That's a win-win.
Right. I don't want the silent MI. If this can help me avoid that, then I'm like, for sure.
Perfect.
Yeah.
Wow. So I am amazed at how you've gone through the process and now look at you. Right. And you look great. You look like a movie star.
Well,
I'm glad you look like a movie
Thank
star.
You, bro.
So as you look back, and I know there are people that are picking up their journey with diabetes at different spots. You talked about gestational diabetes, and you didn't fall into the category that many African American women fall into, that maternal fetal death conundrum.
Right.
But we know that we are the
thing.
highest risk in gestational diabetes, pregnancy-induced hypertension, preeclampsia are all things that impact us. Those social determinants of health are real. The CDC has a strategy where they're trying to identify, reduce, and energize communities to reduce that. So if you were to give 3, 4 tips to women who maybe had gestational diabetes or that are battling with diabetes now, what would that be?
I would say, 1, find a good PCM.
PCM is?
Primary care manager. I love acronyms. Exercise. I wish when I was younger that being that my parents were diabetic, they would have maybe encouraged me to be more athletic, exercise more. I do with my children. Like you said, they're both in swim, which is a heart healthy sport and a life skill. But I encourage them early and I tell them about my journey. I think if they would have impressed upon me what it was like to be diabetic early on, I might have changed my habits sooner. I'm raising them to be mindful of health. I didn't have that growing up. And then eating right. And when I say eating right, I've never been on a diabetic diet, but what I have done is portion control because obesity
is real.
It's real. And it's interesting. Both of my parents were diagnosed later on in life, even later than me. I'm talking about 50s and 60s. So you know it was lifestyle, right? So I do portions. So I tell people I kind of eat whatever I would like, but I do it in small dollops.
Yeah.
I literally dollop my plate because I don't want to restrict myself. So it's something that I can't stick with. I want to be able to enjoy food, but I don't enjoy it in excess anymore. And part of that was Ozempic. It kind of changed my mindset to say, I don't need to eat a lot to enjoy this. I can still enjoy it in small amounts. And so I can attribute some of that to Ozempic. So changing your mindset.
Look, see, you just took the playbook that I always like to say, right? And people know when I talk about lifestyle medicine, I ask people, did you take your meds? MEDSS. The first one being mindfulness. Did you change your mindset? And it seems like when you got that diagnosis of gestational diabetes, there was a switch for the baby. But then you realize this is for life. Exercise. My goal is to get to this many days, but right now I'm at 3, but I really want to bump it up. You're setting those targets and you're still working at that. Diet, you talked about it. I can't remember the name, but he's a physician that talks about eat real food in small amounts frequently throughout the day. And again, you didn't hear me say vegan, vegetarian. You eat real food. For the most part, most of that is going to be things that grow from the ground, right? The first S, sleep hygiene. Something that I got to work on. Making sure you're getting enough sleep, because when you don't get enough sleep, your body sees that as a stress. And when you have stress, cortisol.
Yes, I'm about to say, if I don't get enough sleep, my blood sugar is up in the morning. I'm like, well, I didn't eat anything.
That's why your body says you're stressed out, right? The next S is getting rid of risky substances. Now, you don't do the energy drinks and all that crazy stuff, but if you think about it, many of the candies that we eat in this country are banned in other places.
Interesting.
And then the final S is something that I'm still learning from you. It is being socially connected, making sure that you develop a community where you not only benefit, or your children not only benefit, but you create an environment, whether it's through your church, which I know you're actively, whether it's through the type of work that you do, whether it's through the mentorship pathways. I've been over here when you've invited people over just because they either mentored you or you mentored them. Those are the things that I describe as taking your meds, and those things are the 6 pillars of lifestyle medicine. No, you have to run. It's been wonderful. As I've learned a lot. I know that with that MBA, I'm gonna help you manage some of this business. But as we
Air Force sponsored.
There you go. It's a pathway. That's a thing that a lot of people don't appreciate. But as we close out, is there anything you would want to let people know?
I would like people to know that diabetes can be managed. It is essential that you manage it so that it does not take away from you the things that you love, i.e. your health, time with your family. I've been diabetic for a lot of years, and you should not look like you're diabetic.
Beautifully said. Couldn't have said it better myself. But understanding that the disease should not define you. The fact that you embraced it and said, okay, you gave me this problem, I'm going to embrace it and change my life. Now, what's the acronym NIFE? You said you like acronyms. This is one you can take with you.
I like it.
LIFE stands for Living Intentionally Forever. As I mentioned, this is Dr. Batts with the About That Life podcast, having a riveting discussion about diabetes. We want to thank and appreciate it, and we're going to have her back. When we have a discussion about preoperative evaluation and surgery, we are going to have Teresita Scott back with us to embrace this concept that she has of life. And I truly had the ability to take a step back, to look back and then move forward, as you all should do as well. Remember to live intentionally forever.
We hope you enjoyed this episode of the About That Life podcast. If you did, give it a like, subscribe, and share it with a friend. And remember to be about that life.